Hello, everyone. My name is Captain David Wong. I'm a pediatrician and a senior advisor for sickle cell disease in the Office of the Assistant Secretary for Health. Welcome, everyone, to our inaugural session for the Sickle Cell Disease SOAR series. Next slide, please. SOAR stands for Services, Opportunities, Activities, and Resources. And this is our new series to enhance quality of life for sickle cell disease warriors and their families. With each of these sessions, which we plan to have every 2 months, this provides an opportunity for the sickle cell community to meet different federal agencies, learn about curated resources, and gain knowledge and skills to help warriors and families thrive and soar. Next slide. With this first session, and hopefully people can hear me, I'm going to try to talk a little bit closer to the computer. I just saw a chat comment. Our run of show for this, we're going to start, because this is really driven by requests from the warrior community to provide more resources about quality of life. We wanted to start every one of our sessions with a TED Talk from a warrior to really ground us in the community and what the community's needs are. After the TED Talk, we'll have our featured presentation from SAMHSA and mental health resources. And then we'll have 20 minutes for questions and answers. Feel free to enter any questions in the question and answer box. A copy of the slides and written responses to questions will be shared with attendees afterwards. And this event is being recorded and will be posted to the HHS YouTube channel. Next slide, please. So before we get started, we just wanted to get a sense about who's here. So we're going to have a polling question, and I'm going to ask our team to put it up. And I know that many people may wear multiple hats, but just choose the best answer, and we'll give folks about 20 seconds or so. Okay, so we got a mixed audience here. Warriors, advocates, health providers, and others all represented. So this is great. This is good context to know as we continue our session. So next slide, please. So I'd like to introduce Mr. Eric Kirkwood. He's a warrior from Kansas City, Kansas. He received his bachelor's degree from University of Arkansas at Pine Bluff. He is also a former president of the Uriel E. Owens Sickle Cell Disease Association of the Midwest. And he's currently working in the Kansas City Public School District. So I'll hand over the microphone to Eric. Thank you so much.
How you doing today? I've had a long experience with sickle cell. When I was growing up, I never had a crisis until I was 17 and about to go off to college. And that's right at the time of your life when you're trying to make decisions about career and all those kind of big decisions. So it was really kind of traumatic for me to start having the sickle cell crisis right when I need to be doing other things. But I've had every kind of side effect from sickle cell, from gallbladder to spleen to lung issues, priapism even. So, and multiple crises. So, it's been kind of rough, especially in those early years after I had my first crisis, and I started having multiple crises. crisis after crisis. And then in about 1999 or so, I got on hydroxyurea, and that really changed things for me. I didn't go to the hospital again for like 10 years, and so that was a real help for me. But the stress of having sickle cell, a lot of times you don't know when you're going to have a crisis. It just kind of pops up on you, and so you have a lot of anxiety with that. Um, it's you never know what's going to happen to you, so you have that looming over your head all the time. So that that definitely affects your mental health. Um, I I started going to I went to a psychologist a long time ago. I guess I was still in my late 20s, and it seemed like it helped some. And I've seen psychiatrists or psychologists since then. I went to see a psychiatrist one time. It wasn't what I expected. I thought I was going to get to lay on the couch and tell all my, like Tony Soprano or somebody, telling all the things that are going on in your mind. But she just basically wanted to prescribe antidepressants. And I've taken antidepressants before, and I don't know if they work or not, but because it seems like your mood can change, depending on your circumstances anyway. Um, but as I've gotten older, I'm 64 years old now, and it's been more difficult for me in the past couple of years dealing with sickle cell than it has been in previous years because I'm getting older and I think about my mortality more often. Um, I still have random things that happen to me as far as my health. I rarely have a sickle cell crisis anymore, and I feel pretty strong all the time because I'm doing red blood cell exchange every every 5 weeks, and that's really helped me out a lot. It's physically that is, but when I was younger, I didn't I couldn't participate in sports. I was kind of skinny. Um, I never had I never was bothered with other kids teasing or bullying me or anything like that. But I didn't have great self-esteem because my physical development was slower than my peers. And even when I was in high school, I mean, when I was in college, I still looked like I was 16 years old. So that's a good thing, but um, I was just wasn't physically developed as my peers, and so a lot of that affects your self esteem and how you perceive yourself. And for a long time, I had really negative thoughts about how I looked or different things like that, or just my self esteem was low. Um, so that's one of the things that you have to deal with uh, mental health and sickle cell. Um, and because of sickle cell, I was afraid to make commitments as far as like career or getting married or anything like that because, well, frankly, I didn't know I was going to live this long. but but as I've gotten older, um, things had gotten better to a degree. But still, mental health things are a big issue for me. Last 2 years, especially, my father passed because I had a lot of responsibility taking care of him, and he was in assisted living, and I basically had taken care of him for 5 years before he passed, and I had to deal with that, and I don't even know if I even grieved for my father. I lost I lost my sister to sickle cell when she was 34. Um, and sometimes you have survivor's guilt, that kind of thing. But one of my colleagues mentioned that to me about survivor's guilt. But I didn't have a lot of guilt or grief um, with my sister's death. But grief is another thing that you have to deal with because you may lose a friend with sickle cell, or you may be grieving for yourself because of the situations that you're in. I've been pretty lucky. I've lived a good life, and I've traveled mostly over all over the United States. I've been to Jamaica a couple of times. I've always participated in some type of community activity. Um, I used to work with the AmeriCorps program, and most of my experience had been in education. And but I never made a lot of money because I didn't work all the time. So having to deal with lack of funds sometimes, that definitely can bother your mental health. You can sometimes do what you want to do. But I um, I have had experiences with psychologists, and is some of them have really helped me, but I've kind of learned a lot of stuff on my own. I did a lot of research on sickle cell over the years, and I had a journal that I'd been keeping since 1983. And journaling is one of the things that can help you deal with depression. Also, I learned to practice transcendental meditation. That's another thing that helped me too. Um, so I've had a decent life, but I have had a lot of feelings of self doubt, low self esteem, things like that. Um, those are those are basically some of the things that I've dealt with as a person with sickle cell, and it's just a lot of stress. You're always under stress because you just never know when you're going to get sick, if you're going to get sick, or how you're going to react. Your body's going to react in a certain situation. Like I was on a trip to Seattle. We stopped in Colorado, and I went up in the mountains, and I ended up in the hospital. So things like that you have to be smart about, but you just never know what's gonna happen. And like now, like I said, excuse me, I don't have problems so much with sickle cell anymore, but it's other things like all this summer I've been dealing with sciatic pain, and that really got me down. Yeah, it was very very painful. It was worse than a sickle cell. But you know, when things like that happen, it just kind of drives you into a bad mental state. So you have to be aware of your mental state, and you have to try to do something about it. So I would stress uh, getting mental health from a psychologist or psychiatrist, um, so that you can find some other ways to cope with dealing with sickle cell. Um, Also, pain medicine contributes to depression too, because it just kind of slows you down. Um, you're kind of withdrawn. So I think that plays a part in it. Um, another thing that's good for sickle cell, well, I mean not for sickle cell, but for your mental health, is to be involved in things. Getting, clubs, organizations, working. So it's it's really difficult, and the thing is you have to learn to count your blessings too. And even you, even though I've had a good life, I still like, I haven't done enough what I was here to do. Just about insecurity. Um, I would just suggest if you're having depression, which is considered normal, if you have a chronic disease. I think that this comes with the territory. But get some help. Um, Learn how to meditate, exercise. Exercise has really helped me too. So try to find ways that it can help you beat depression. And don't try not to be alone. Try to be active and involved with other people because that's hard to be depressed around other people. But yeah, just I would say just be aware of yourself, how you feel, how your body feels, um, and act accordingly. There are a lot of things that that I did actually gave me a crisis, like going up in the mountains when I shouldn't have, or exerting myself in certain ways, like exercising or something like that, or just being under a lot of pressure and stress. So it's mental health issues are probably next to the pain and physical effects of sickle cell. I would say that your mental health is probably second, and it's very important because you get into the real depression. And I know people have. I worked for the Sickle Cell Disease Association for years, and people would overdose because they were taking their medicine improperly, or they would, that a lot of people pass, and it's just that what I'm trying to say. It's just very difficult dealing with sickle cell and whatever, if you have it or if you're dealing with other people that have it. And that can that can affect your mental, excuse me, that can affect your mental health as well. So I'm that's about all I have to say. That my experience with mental health and sickle cell. I probably could think of some other stuff, but that's all I can think of right now.
Well, thank you, Eric, so much for your courage in sharing your story, your journey, your resiliency. I think there's a lot of folks on the call are going to, resonate with some of the things that you said. And there are several questions that folks have been asking while you were speaking. And if you have a chance afterwards, please feel free to type in some of the responses to those questions during this event. And we may have time to answer some live questions from you at the end as well. So thank you so much, Eric.
You're welcome.
I'm going to move on now to the next agenda item. If we can move to the next slide, please. So our featured speaker today is Dr. Neeraj Gandotra. He is the Chief Medical Officer and an addiction medicine specialist from SAMHSA, the Substance Abuse and Mental Health Services Administration. And we're going to learn more about that agency and their resources today. Dr. Gandotra received a BS from the University of Maryland, his MD from Unive School of Medicine, and did his psychiatry residency at Howard University. Dr. Gandotra is also our lead partner and collaborator between SAMHSA and OASH on our sickle cell portfolio. And you may remember Dr. Gandotra for those of you that attended our Thriving Warrior mental health panel last month. Dr. Gandotra gave opening remarks for that event. So we're very grateful for all of his contributions and collaboration with sickle cell. And with that, I will hand over the microphone to Dr. Gandotra.
Thank you, David, for the warm introduction. Thank you, Eric, for sharing your story and your journey. I heard a few themes that came through your story that I will certainly touch upon today as well. And the biggest take-home message I have for all those attending is that there are resources available and that you don't have to do this alone. We can go to the next slide. I'd like to just let everyone know, we'll go over some things about SAMHSA, the Substance Abuse Mental Health Services Administration, some resources. I'd like to extend Thanks on behalf of our Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman. And I'd also like to thank the Office of the Assistant Secretary for Health, and not only for the invitation, but the opportunity to collaborate. We are very thankful for that. We can go to the next slide. So no disclosures to report, no conflicts of interest. We can go to the next slide, please. So we come to the first polling question, and this really does speak to the idea about stigma. And how comfortable are you? Are you comfortable in discussing behavioral health issues with your sickle cell disease specialists? And for those who are providers, how comfortable are you discussing behavioral health issues with your patients? I'll give folks a couple minutes to respond. Or excuse me, a few seconds to respond. As folks are putting in their responses, I couldn't help but think about how the impact of chronic illness, how it impacts a person's sense of self. And I heard some things about negative thoughts, the stress and grief, and also the isolation. And that's sort of where we're going to pivot to. You can see that about 50% of folks are comfortable in speaking with their provider. And that's great to hear, that so many folks are able to, but that does mean that there is a gap in either the provider's competence in being able to handle those conditions, and also the stigma that sometimes surrounds behavioral health conditions, because there's been historical shame and stigma attached to mental health and mental illness that, while we've done a good job in increasing awareness, still persists. So we're going to talk a little bit about the effect of stigma as well. But what I also heard from Eric that I think we're going to touch upon is the tools that he utilized in terms of resiliency through gratitude and having connections. But I do think that that's going to be the key, is to recognize that we're not alone. The providers are not alone, and those with sickle cell disease are not alone when it comes to managing their behavioral health conditions. Let's go to the next slide, please. So I'll go through this fairly quickly. We're going to go fairly high level through many things, but this is just a few moments about SAMHSA. We're part of HHS. I like to call us the behavioral health arm of HHS. Majority of the things that we do is we give grants. We give grants to the states. We give grants to nonprofits for substance abuse prevention, substance abuse treatment, substance abuse in terms of technical assistance. But we also give mental health service grants. And we collect data, and we provide some information in the form of technical assistance to organizations, advisories for public use, and we have a number of offices and centers to help push forward our mission. Next slide. So we're going to talk a bit about why it's important to do concurrent care. I use the word integrated here, but concurrent with behavioral and physical health conditions. We know that when we do concurrent care rather than sequential care, we get better outcomes. And then we'll go over some SAMHSA resources and potential opportunities to support the work that's being done through providers of sickle cell disease. Let's go to the next slide. So I'll talk a little bit about integrated care through our strategic plan. As you can see, our strategic plan has underpinnings of equity, trauma-informed approaches, recovery, and a commitment to data and evidence. But our 5 priorities are preventing substance use and overdose, enhancing access to suicide prevention and mental health services, which are very key to managing chronic conditions like sickle cell disease, promoting resilience and emotional health for children, youth, and family. Certainly something that is very close at heart to those who are dealing with sickle cell disease and the families that support them. And integrating behavioral and physical health care. The idea that there is no wrong door for when a problem is being discussed, when a problem is identified. Doesn't mean that every service has to be provided under every roof, but providers should know where to go when they're encountering behavioral health conditions. And of course, that means then educating the behavioral health workforce. And like to say that we envision that people who are affected by or at risk for mental health or substance use conditions receive care, achieve well-being, and thrive. Next slide. So I'm going to go over a little bit of data just so people get a sense of how prevalent these conditions are. And I will say that when these slides were first created, we had 2022 data. We've now since released 2023, yet the data is quite similar in terms of the numbers and percentages. But you can see that almost 84 million people have either a substance use disorder or mental illness. Now, out of a population of 360 million, you can do the math in terms of what percentage that is, but that's a significant percentage of individuals with substance use disorder or mental illness. When we talk about those who have both, we're 21 million. And then severe mental illness, that's at almost 15.4 million folks. So it's important to recognize that 46.5 million have substance use disorder and almost 60 million have have mental illness. So that's, roughly 1 out of 6 people. And the prevalence is even higher for those who are dealing with chronic conditions. And that's where we'll focus upon today. Next slide. So despite those millions of folks who have mental illness or substance use disorder, only a small percentage of them are actually receiving care. We do a little bit better job with those with mental illness, but still, at best, we're at a third to a half of patients who have an identified condition and then are receiving care. And then when we think about substance use disorder, we do far worse. And that's in part due to the stigma that's attached to substance use disorder, and in part due to provider training. And SAMHSA and HHS are committed to improving treatment access. We know that if we talk about mental illness and we help to decrease the stigma, there needs to be a place where patients can get treatment. We know that we can't do it in specialty treatment centers. Our colleagues at primary care and specialty care and the various medical disciplines need to also carry some of this. And conversely, our behavioral health providers may need to do more in the physical healthcare space to ensure that care is coordinated. Next slide, please. So this is really the crux of the issue. Individuals with sickle cell disease experience higher rates of depression, anxiety, and insomnia. It's not surprising as they undergo uncertainty about the disease course, complications, and that causes a lot of stress. The pain episodes themselves can be quite traumatic. And then when they're not actually able to receive appropriate medications or treatment for the pain, it can be further traumatizing and increase anxiety. And of course, I heard some things about uncertainty as Eric was discussing his journey through this. And frequent hospitalizations make it very difficult to not just logistically to plan things, but people definitely feel then more isolated. They feel like it's difficult for them to move forward in their lives when they don't have certainty. Um, of course, insomnia can be related to pain, can be related to anxiety, but in addition, not getting truly restful sleep can lead to behavioral problems, and of course, decreased efficiency in their daily activities. And we know that this doesn't just affect the person, it affects their caregivers around them, it affects the family around them, who also have significant sacrifices that they make, taking time off of work. Certainly consistent worrying about the health of their sibling or their child when it comes to how they're going to manage. Parents in particular are maybe worried about um, the vitality of their children. And on top of that, there is this shame and stigmatization that occurs that leads to poor treatment adherence. We call it compliance in our medical speak. Patients don't take the medications that are prescribed or as directed because they don't feel connected to the provider. They don't feel the provider is connected and invested in their success. That can also lead to increased pain, increased episodes, which then lead to greater disruptions in life. And ultimately, though, this comes down to trust. Trust that their healthcare providers have their best interests in mind and that medical institutions are invested in them getting better. So there's a lot of data out there about how common mental health conditions are with individuals with sickle cell disease. And quite frankly, it ranges from 20 to 57% for depression, almost as high as 30% for anxiety disorders. But the important thing is that this is much higher than the general population. And that is due to the reasons we've stated above, that patients are going through stress, pain, mistrust. Their compliance with medications and treatment are not as high as they could be. And that really is not only related to trust, but sometimes these approaches are not necessarily concurrent. Patients, and they're disjointed. Patients will get their sickle cell care in one place, their mental health care in another place. They're not always having providers talk to each other. And a lot of times patients feel like they're tired of going to so many doctors. They have to go to different doctors for different medications. It's quite disruptive in their lives when they have to go to the pharmacy multiple times. Lots of other issues that when you factor that onto the fact that they may get a crisis at any time that completely disrupts the schedule, it can be demoralizing. And I want to really highlight the difference between demoralization, because demoralization is something we can sometimes address through behavior by changing some of the social determinants of health, by improving connections that may improve outcomes too. Next slide. So I did want to talk a bit about substance use disorder and sickle cell disease. One of the most important things to remember is that while chronic exposure to opioids for pain management can lead to higher levels of tolerance, and that may require higher doses, that is common for any condition. The more you take something, the higher your tolerance becomes. That's true for coffee. So I wanted to normalize that individuals who are frequently in crisis may need higher doses for them to get relief. But multiple studies have shown that there's only a marginal higher prevalence of opioid use disorder, despite needing more. What's most important is that when they're in crisis, they get the treatment that they have to relieve the crisis. There is emerging data, however, that alcohol use in individuals with sickle cell disease may be higher than that of the general population. I put forward some of our National Survey on Drug Use and Health data for the general population. But alcohol use disorders can also be related to symptoms of, or excuse me, can be related to depression. There's high co-occurrence of depressive episodes in individuals who have alcohol use disorder as well. So there may be an interconnection here between the depression and the sickle cell disease affecting the frequency of alcohol use and the severity of the alcohol use. Next slide. So here's a quick look at the data. When we think about individuals who have mental illness and the services that they receive, we really think about this biggest part. 39% of Black or African Americans receive mental health care compared to non-Hispanic whites. Yet they have similar rates of mental illness. And when it comes to substance use, they have similar rates, but there's a big unmet treatment need. And this is also related, as patients have experienced, not just in behavioral health care services, but in general healthcare services. There have been multiple experiences of bias. This has been stemming from structural and historical and systemic racism and discrimination. And then there's unique to Black and African American communities, mental health stigma. It is something that I think we've made a lot of inroads in, but yet still persists. And then there is functional and realistic mistrust in the healthcare system based on historical encounters, as well as access barriers and current negative encounters. We know the workforce, we're already short in terms of mental health workers. Psychiatrists, we're short 10,000 psychiatrists, maybe 5,000 child psychiatrists. And yet we're even in greater need of psychiatrists and psychologists who are Black. People want to be treated by folks that, you know, share their cultural and social backgrounds. We need more cultural competent providers. We need to increase the workforce. All of this data is collected from SAMHSA's African American Behavioral Health Center of Excellence. I encourage you to visit that to look at the data that they have and the workforce investments they're making to improve this disparity. Next slide. So integrated care, as I mentioned, is important. What really is the bottom line is providers need to talk to each other. They need to discuss the care. It can go on various levels. Some providers have greater levels of resources that allow them to do more. But at the very basic level, I think care needs to be coordinated. At least if a patient is being screened for mental health conditions or substance use disorder, then you have a problem that you've identified. You may not be able to provide all the services in your clinic, but you will be able to help them find those resources, whether that be through a patient navigator, utilizing treatment.gov or the treatment locator on SAMHSA's webpage. But there are resources available. I'd say at the very least, even 988, our lifeline, is a place where patients can reach out and obtain at least the connection to some resources. Co-location certainly is better, that if the center has both services in the same building or even on the same floor, but at least on the same campus, because it does take a lot for patients to get to where they need to be in terms of, even I have to go to a doctor's appointment. I've got to potentially arrange, you know, coverage for my work, for my childcare, get transportation, pay for parking, all of those types of things. So if they're in the same place, it's even better. But system level integration is the ideal, where not only providers talking to each other, but the systems have an integrated healthcare record that checks against medication interactions, that looks at the visits and treatment plans of various providers and makes sure that those providers are talking to each other. And this is also from our Center for Integrated Healthcare Solutions. SAMHSA and HRSA have a joint project. You can certainly visit our web pages there as well. Next slide. So we've been doing a lot in terms of trying to increase the existing workforce capacity. There have been regulatory changes. You may have heard of 988 in crisis services. At any time, 24/7, 365 days a year, any person can call or chat, text 988 and get connected to a person who can actually get them to the right resources. I tried this myself for patients to ensure that they were able to get connections when they traveled across the country. They needed services in a different state. We were able to locate them when they needed them. SBIRT, screening, brief intervention, and referrals to treatment. This is something that any clinic, any provider can do. And it is reimbursable by Medicare, Medicaid, and all of the various insurance providers. At the very least, you can screen, and then you can decide with the patient how to intervene. It doesn't mean that you have to provide all of the treatment services, but you've identified the problem. We also have CCBHC, Certified Community Behavioral Health Clinics, which we expect to carry some of the load when it comes to actually having the behavioral health clinic monitor some of the conditions, the physical conditions that a patient may be going through. But we know we can't do it alone. The providers we have may not have all the capacity. We're going to have to enlist peers. We have a peers support center of excellence, and we know that the peers are vital for keeping patients in treatment and overcoming resistance. Finally, we're looking at telemedicine as another way to increase access. There's many communities that don't have easy access to mental health care, but we know that if they have access to a phone, then they can potentially receive services. And the Center for Medicare and Medicaid Services are allowing for telemedicine in terms of behavioral health care. Next slide. So I know this is a regulatory issue, but I wanted to at least highlight it because it does have an intersection here. A lot of times providers were afraid to talk to substance use disorder treatment providers in particular, because there was a different set of rules that they had to follow when they discussed the care, when they got records. That has now changed. Now the regulations for confidentiality and disclosure more closely align with HIPAA. One set of rules, and the records don't have to be segregated. That's the only take-home message I want folks to know, is that providers can talk to each other with fewer barriers. Next slide, please. So I mentioned 988 already. This shows a timeline of this lifeline. This is not just for suicide prevention, but also for substance use disorder. It is important that every provider know about this and every patient be reminded of this so that they're not alone. 11 o'clock at night or 2 in the morning, they can still reach out and find someone who they can talk to. And this is available in all 50 states. We've invested $1 billion to ensure that we are monitoring response times and coordination and follow-up after the call as well. Next slide. So I mentioned SBIRT, screening, brief intervention, and referrals to treatment. Just to highlight that this allows any provider a framework on how to screen for substance use disorder and then refer the patients as necessary. We have resources on our web pages. We give grants to various universities to teach this, but it is a reimbursable activity that every insurance provider pays for. I saw a question in the chat. Yes, these slides will be available, and I will say they are all available on SAMHSA's web pages too. Next slide, please. So I mentioned CCBHCs. We want them to shoulder some of the burden of physical health care. Certainly outpatient primary care screening and monitoring is one part of it, but they also will provide psychiatry care in terms of rehabilitation services, outpatient mental health and substance use disorder services, and crisis services. There are 9 core activities that they are required to have. We have over 500 CCBHCs across the country. If you're a sickle cell provider and you know that your patients are having behavioral health issues that may be too great for you just to manage on your own, these are great partners to have to coordinate with, as they are required to help you monitor some of the conditions, some of the aspects of the conditions that you're treating. But most importantly, the care coordination is where you can talk to them and they can talk to you. And they also provide peer, family support, and counseling services as well. Next slide. So these are for the providers on the call. We have technology transfer centers. So I've talked about ideas, but how do you actually implement it? What infrastructure do you need? What type of staffing needs may you encounter if you want to implement some of these services? Our prevention and addiction technology transfer centers can actually answer those questions. If you have specific clinical questions on how to manage substance use disorder, our provider clinical support system will actually have clinicians that can answer the question, about what to do about a particular dosage. And if you're dealing with individuals with severe mental illness, we have SMI Advisor. This is also an analogous program where you can call and speak to a clinician about how to manage a particular mental health condition that you may be trying to help a patient get through. So it's important that you utilize these. We have over 40 training and TA centers. I'd say it's probably 50 or 60 at this point. We've been investing a ton into making sure that our workforce is well equipped with resources. And then our National Training and Technical Center for Child, Youth, and Family Mental Health. The family unit is affected by this, not just the person that is dealing with sickle cell disease. And certainly there are resources available there as well, as you may be treating the person, but you also have to provide some support to the family as well. Next slide. So we're near the tail end. I wanted to make sure that everyone had the resources again. If you're in a crisis, you can call the 988 Suicide and Crisis Lifeline. If you need to find treatment, we have Find Treatment at SAMHSA. We also have links to the state or jurisdiction where you live that can provide you with directory information about your state agency websites. And if you need support, findsupport.gov. Next slide. So this is also for parents and those who might need to talk to their kids about this. Dealing with chronic illness is going to be taxing. All of these are links, and the slides will be available. There's a particular guide on strengthening parenting and enhancing child resilience. Certainly very topical for children who may be going through all of the anxiety and stress of a chronic condition like sickle cell disease. And then for organizations like pediatrics offices, pediatricians' offices, and those who may be treating sickle cell disease in children and adolescents, this is important for those organizations, how to identify the mental health and substance use problems. And then our Talk They Hear You campaign. These are for parents, and this I'd say is general for anyone, whether they have a chronic condition or not. The Talk They Hear You campaign, how you can talk to your kids about the risks of alcohol, opioids, cannabis. It's important that at least, if you talk to them about it, you tell them about the risks, their actual use goes down or their risks go down. We've seen this with tobacco. We've done a tremendous campaign on reducing tobacco use in youth. And I could say it's less than 16%, when in 1950, before all the information came out, we were at 50% of the US population was smoking. Now we have tracked that very far down. We know that kids, when they get educated on the risks, they don't engage in that behavior. And then a couple resources about chronic pain. You can take a look at our SAMHSA store, our evidence-based resource center, and take a look at all of the resources we have. It's important to recognize that that these conditions are intertwined and treatment should be concurrent. Next slide. So again, find treatment.gov, find health and support for mental health, drugs, or alcohol. And then for those who might have issues with how to pay for treatment, we have a guide on how to pay for treatment. We also have a guide because there's a lot of trauma that's associated with this for providers on how to implement a trauma-informed approach to make sure that the language we use isn't stigmatizing and pushing patients away or keeping them from opening up so that you can get the best care. We know that individuals who are depressed or anxious may not be as compliant. We know that they also may not talk if they don't feel like they're being welcomed and their condition isn't being recognized, or if they're being defined by their condition rather than being treated as a person. We also have resources for peer support and supporting the peer workforce in mental health. We got lots of resources. I would encourage everyone to peruse and do some light reading on our web pages. Find out what works for you, what might be useful. You can download it, you can print it, or you can just read it. Next slide. And I know I've gone a little over. I'd like to thank you all for the opportunity to discuss these things. And I'd like to thank you all for listening to what we have to offer as well.
Thank you so much, Dr. Gandotra. That was extremely informative. Really appreciate you giving us that overview of SAMHSA and for curating all of these resources, grant opportunities, links, all in one place. And just as a reminder, this slide will be shared with all registrants and attendees later. So we have now about 7 minutes for questions. I'd like to invite Eric back to the session if we can turn his camera back on. And Eric, hopefully you had a chance to see there were all kinds of positive, very affirming, supportive comments in the chat. So I hope you had a chance to read that. And there were some questions I just wanted to give you a chance to answer, Eric. People wanted to know your sickle cell type. And there was also a question about how did you develop resiliency and encouragement in your youth?
My sickle cell type is SS. I didn't have a lot of crises. I had a lot of fetal hemoglobin. That may have been one of the reasons why I didn't have when I was a little kid. I just always like that I was going to figure out a way to sell. And I did a lot of research and trying different things like diet and herbs and, you know, just all that kind of stuff. And it seemed to help me be more resilient physically. And so my attitude mentally was like, I'm just not gonna let anything get, you know, I've got to break this, break sickle cell and not let it break me. But I guess in a way, I feel like I've beaten sickle cell. I've lived this long. I've had a decent life, everything. But I still, you know, have depression and self-doubt and start to think about my mortality, which I never really did because I'm not really obsessed with that or anything, but just the fact that I'm getting older kind of makes me think about that. And, yeah. Okay.
Thank you, Eric. The next question is for Dr. Gandotra. And so there's many questions. We're only going to get to a few of them. But one of the questions was, can you describe some of the common brief interventions for dealing with people with chronic disease?
Thank you for that question. The first thing I would say is that when we talk about individuals that are dealing with chronic disease and the interventions that are most helpful, it's important to understand that the person is not alone, the provider is not alone. And sometimes individuals who have frequent episodes, they may go to the emergency room more often, and they may be considered higher utilizers of those services and sometimes be inappropriately labeled. We all know the wait rooms in the emergency room are, quite frankly, in most places, too long, and that may be due to a variety of factors. So the emergency room may not be always the best place. The best intervention is really more frequent, regular contact with the providers, even if it's shorter intervals of time. And we found this to be very helpful in the mental health space as well, that if we meet with patients more regularly, it's no secret. The more time you spend with them, the more effective your treatment will be. That we're actually able to identify the problems. We're able to have the patient feel more connected because they know I'm going to meet with a provider next Tuesday. I'm going to meet with them again on Thursday or the following week. And they know with that regular contact that they're not alone. So they'll be able to be not only more connected, but the provider will be more responsive because they will have seen the patient longitudinally for a longer period of time and get a better sense on how to manage.
Great, thank you. And we'll take one more question here. This is for Dr. Gandrocha again. What do you recommend can be done to improve the stigma among clinicians that exists around sickle cell disease?
Well, a couple things. First is we're already working with the CDC to revise the guidelines for chronic non-cancer pain management. We know that it's important to recognize that a crisis is a crisis. And the most important part with regard to stigma was recognizing how important it is to look at the objective signs of distress, and make it a very clear-cut assessment that the provider will make. Providers know, they really do know when patients are in distress, and to have them trust their gut, trust their senses, but also follow some objective evidence, the heart rate, the blood pressure, the amount of sweating that a person has. Those things in crisis certainly are ways that we can quantify pain. But when it comes to stigma, we have to humanize the condition. We did a pretty good job when it came to destigmatizing HIV because we talked about it, we talked about it. We taught medical students, we taught nurses, we taught the Joint Commission about how important it was to address this problem so that everyone gets screened for it now. Everyone has testing at some point. The same sort of thing has to happen on a multi-pronged approach with regard to sickle cell disease and chronic pain in general, that it has to be part of the curriculum. It has to be regularly reinforced through medical licensing renewal. It has to be looked at by the accrediting bodies like Joint Commission and other entities. Then we'll be able to know. We have to test for it, essentially. That's how we learn. And that's how we change behavior. We start testing about it, then we'll be able to testing providers' competency on it. Then we'll change their behavior.
Thank you so much, Dr. Gandrocha. Next slide, please. Unfortunately, we're near the top of our hour, and we had so many questions we didn't get a chance to get to, but we are planning to have those questions answered afterwards, and we will send a transcript of the Q&A to all attendees and registrants later, along with the slides. And so just in the final minutes, I hope folks have enjoyed this session today. Again, this is our first session for this quality of life series for warriors and families and providers. And our next one's scheduled on a bi-monthly basis, roughly, is going to be on housing, and we'll have a speaker from the Department of Housing and Urban Development, or HUD. The exact date for that is not set yet, but we will send out a registration link to everyone who registered for this session later. I also want to flag that we have our inaugural HHS Sickle Cell Disease Summit, which will be convened by Secretary Becerra on September 24th here in Washington, D.C. So I hope some of you are able to attend this. The QR code is here for registration. And I want to remind folks that we created a new sickle cell disease resource box, SCD at HHS.gov. So please feel free to share any questions, comments about this series, or any other programming happening across HHS with sickle cell to that email box. And next slide. And we'll skip this polling question for time, but go to the next slide as well. I just want to end the session really thanking again our speakers. Thank you, Eric, again, for your courage and bravery, for sharing your story. It's very powerful. Thank you, Dr. Gandocho, for that very informative presentation. We're so encouraged and grateful for this relationship that we have that's growing between SAMHSA and HHS OASH. And thanks to all of you listening, over 200 of you who tuned in today. Thank you for supporting this effort, and we look forward to seeing you at the next session. Thank you, everyone.